Welcome to Beyond the Diagnosis, a show where we break down the barriers of medical science and simplify the complex jargon for your understanding. I am Dr. Ashish Philip, an orthopedic surgeon, and with me, my co-host, Dr. Viroshni Harikrishnan, a health strategist. Today, we will be discussing about cardiac health and why are young and healthy individuals dying of sudden heart ailments. So, Dr. Viroshni, if you could do us the honor of introducing our guest of the hour.
Hi, all. Most certainly, Ashish. It gives me such pleasure to introduce Dr. Venkatesh, who is a renowned doctor in the field of interventional cardiology. He has over 20 years of experience as an interventional cardiologist and has completed over 15,000 diagnostic catheterizations and more than 3,500 interventional procedures in the catheterization laboratory. Dr. Venkatesh completed his MD in internal medicine from the prestigious PGI-MER at Chandigarh, where he was the batch topper and also won the First Order Medal. He then went on and completed his DM in cardiology from PGI-MER, Chandigarh in 2001. Dr. Venkatesh has done numerous clinical studies and published book chapters and articles in national and international journals. He has a special interest in preventive cardiology. Outside of medicine, he blogs and is a dog lover. He now leads the Department of Interventional Cardiology at a leading hospital in Bangalore, India. Hello, Dr. Venkatesh, and welcome to Beyond the Diagnosis.
Thanks, Dr. Viroshni, for that generous introduction. It's good to be with you guys talking about a very important topic. Thank you so much for having me here.
Thank you, Dr. Venkatesh, for coming on our show. I know how busy you are and you've taken the time out to come and do this. So, Dr. Venkatesh, I got to start the conversation with why cardiology? Why did you choose cardiology? I mean, it's one of those, I guess, most satisfying fields. When people come in, they come in with serious distress and then you relieve them. But the complications, I remember being a JR in one of the cardiac ICUs, and that 1 month was horrible for me. I could barely sleep. So why cardiology?
Oh, you could refer to me as an accidental cardiologist because when I finished my MD in internal medicine, I never had the intention of pursuing cardiology at all. I was wedded to internal medicine. I wanted to become a physician. For a while, I thought I should become an oncologist, hemato-oncologist, because I thought that very closely came to near internal medicine because of the problem-solving nature of it. I never wanted these procedures and that kind of a thing. When I finally decided I should do a specialty, cardiology has always been most sought after branch for all the physicians. So I took up the entrance exam. Luckily, I got through. Now, when I finished my DM in cardiology, I was planning to become a non-invasive cardiologist. I wanted to get into clinical cardiology, diagnostics, etc. So when I joined my former boss, who had left PGI and joined a private hospital, when I went and joined him, I told him that I want to get into non-invasive cardiology labs. So the day I joined and reported to him, he said, just go up to the cath lab and start doing an angiogram. I'll come and join you. And I never left the cath lab after that for 1.5 years. So that started, as I said, an accidental journey into cardiology. But then, as you said, yes, it's a field with both rewards and regrets. We have patients whom we can't salvage, and some of them you treat for a long time. You develop a bond with them, and you become a family member for them, and they become yours. And sometimes these are disappointing, but then to add years to life and life to years is a good thing that we see. So I feel energized when a patient who is on a near death situation comes out and walks home. So I think all of medicine is like that. At all fields, you feel that sometimes there are disappointments, but then something you doing good to the humanity is always rewarding and refreshing. So
Absolutely, absolutely.
Dr. Venkatesh, I do have to ask you this. As I was reading your introduction and as I hear you speak, I'm very, very certain that there are going to be quite a few of us listening right now who are wondering, what is interventional cardiology? Like, why the term interventional?
Well, clinical cardiology is something where you sit across a table with a patient, speak to them, try and understand what their symptoms are, examine them physically, get them through certain tests and come and arrive at a diagnosis and give medicines to treat them. Now, interventional cardiology is where certain procedures, surgical procedures performed inside of a specialized room called as the cardiac catheterization lab. So we perform angioplasties, we put in pacemakers, and there are certain other life-saving devices which are inserted, or these kind of procedures are done in interventional cardiology. So clinical cardiology stops at the clinic, and interventional cardiology or invasive cardiology happens in a cardiac cath lab. So this is the essential difference between the two branches of the same science called cardiology.
Thank you for that, Dr. Venkatesh. Thank you for shedding some light over there.
Dr. Venkatesh, I'd like to get into the subject matter of cardiac ailments and why the young are dying healthy. So we recently saw, here in Karnataka, we had one of the actors, Puneet Rajkumar, who recently passed away, a healthy young man working out. We also had a Bollywood actor recently pass away who was quite fit. So what's going wrong with our young and why are the young dying?
Well, these were very unfortunate events that happened. Celebrities, when they pass away, especially when they pass away young, when they leave us too early, there is an outrage. There is a lot of disappointment, and amongst the fans, there is a lot of grief. Now, as you rightly said, there is increase in cardiac ailments among the young. Not going into specifically these cases because I won't be privy to what their medical details were otherwise. What we know today is that the lifestyle of our society has changed in the last, say, 4 or 5 decades. And these are lifestyle diseases. And that's why there is an increase in the incidence of heart disease, prevalence of heart disease, and young people having to suffer through this. Now, what we see is that the lifestyle in terms of diet, sedentariness, that is, lack of physical activity and exercise, and then certain habits like excessive alcohol intake, cigarette smoking, or tobacco consumption, these have all become more rampant in the current society among the young. So these confer a certain risk to the youngsters. In addition, because of the same lifestyle factors, the other things like risk factors like hypertension, diabetes, abnormal cholesterol in the blood, these have also increased. And the youngsters are going through the kind of stress which they have never gone through before. There is more industrialization, more work pressure, more domestic pressure. Financially, people are under stress. After COVID, all of these have got kind of amplified. So there is an increased stress as well. So these factors, that is an altered lifestyle and huge increase in stress of various kinds, have all contributed to increase in the cardiac ailments amongst the youngsters.
Somewhere I read that, by prevalence, if we look, the Southeast Asians generally have a prevalence of cardiac ailments at a younger age group. Is that true? Do you notice that here in India, as compared to the West, that we develop these type of problems, or is it just across the whole world? It's like that.
Well, while more and more younger people are going through heart diseases all over the world, but what you said is true. Now, there are studies which have looked at different ethnicities and how they have heart diseases. It has been shown that compared to Asians, when I mean Asians, I mean South Asians. I'm talking about India, Pakistan, Bangladesh, Sri Lanka. This region, when compared to Caucasians, Chinese, Japanese, have a higher incidence of prevalence of heart disease in them. Not only that, the percentage of the population which is afflicted by heart disease is more, but what is also seen is heart disease comes almost a decade and a half earlier. If the average age of a Caucasian person to get a heart disease, a male is about 55 years and a woman 65 years, we could see that in India or in South Asia, the average age is about a decade earlier, 40-45 years in a male or 50-55 years in a female. So the disease happens earlier. When we look at the anatomy of what happens inside the heart, in the arteries of the heart, when we talk about the coronary blockages and all that, we see that the disease activity, the number of blocks, is more extensive in Asians compared to the other ethnicities. We also see that when the heart attacks happen, not only they have happen earlier, the outcomes, the percentage of mortality, people dying out of a heart attack is more in our population, and the results of surgery or other interventions also seem to be poorer. There may be multiple reasons for this. It could be related to the healthcare infrastructure as well. But the fact remains that the prevalence is high and the occurrence is earlier.
Dr. Venkatesh, as a layperson who might be listening to this right now, they often get inundated by multiple terminologies. You hear things like heart attack, myocardial infarction, heart failure, chest pain. I mean, how does a layperson understand the differences in all these common terminologies and what do they actually mean?
I think it's important and probably worthwhile to differentiate three terminologies: heart attack, heart failure, and cardiac arrest. These are three commonly used terminologies which people interchangeably understand them or confuse between them. Now, when we look at a heart attack, basically what happens is there are three arteries in the heart which supplies blood to the heart itself. Now, if one of the arteries were to block suddenly, that area of the heart muscle which is supplied by this artery stops having oxygen and nutrition. Now, this leads to immediate chest pain, and if the block is not relieved in time, the heart muscle, which is supplied by that artery, starts getting damaged. So, this process where an artery is occluded and there is no blood supply, and because of that, there are certain symptoms such as chest pain, and then the heart muscle will get damaged, is called as heart attack. The other terminology is heart failure. Now, heart failure is for any reason, not just because of blocks, but there are many other causes for heart failure. But because of any reason, if the muscle of the heart cannot pump efficiently, if the pumping capacity of the heart reduces, the heart is unable to pump out enough blood which the body needs. And this leads to symptoms such as fatigue, breathlessness, and swelling of the feet or swelling of the face and things like that. So this inability of the heart to pump blood which is required for the body in an adequate capacity is called as heart failure. Now, all heart attack does not lead to heart failure, and all heart failure is not because of heart attack. And the last term which we should understand about is called as cardiac arrest. Commonly, heart failure and cardiac arrests are confused about between them. Some people think he died of heart failure. That is, suddenly if somebody dies, we tend to use the term, which is not correct. If somebody's heart stops suddenly because of any reason, like if the heart stops pumping, the brain does not get enough blood supply for that period of time, and the patient loses consciousness. And if the heart does not start pumping again, then we lose that patient. So a person dying suddenly is called a sudden cardiac arrest or cardiac arrest. So this is different from heart attack and heart failure. Now, majority of the times, in a good number of occasions, heart attacks are the leading causes for cardiac arrest. So these three terms, heart attack, heart failure, and cardiac arrest, have to be differentiated.
Understood.
Doc, you were talking about how affection of these vessels which are getting occluded causes the heart attack. My question here is that how long does it take, and do we start perceiving the symptoms only after it's fully blocked, or do we start perceiving it, at an early stage? So when is it that we start seeing symptoms for these kind of things?
Well, this could happen in two ways. Usually, for a heart attack to happen, which means the artery to suddenly block, some prerequisites are there. It's very rare for a completely normal artery to block. So that means in the arteries of the heart, there is a pre-existing cholesterol deposition. This is a disease process. We call it as atherosclerosis. So now cholesterol starts depositing gradually and it starts narrowing the artery. So this kind of narrowing is commonly called as blockages. So there is a cholesterol blockage, and the cholesterol is deposited inside the wall of the artery. If you look at an artery as a tube, the tube has a wall and the wall has a thickness, and the cholesterol is embedded inside the thickness of the wall. And covering that cholesterol deposition is the internal skin of the artery. The internal skin is like that pink membrane which is inside your mouth, for instance, the buccal mucosa. So this part is called as the endothelium. Now, for some reason, if the internal skin that covers the cholesterol deposition or the cholesterol block were to break or to crack, Now, the cholesterol which is inside the wall comes in contact with the blood which is flowing inside the tube, and that causes clots to form. Now, if the clots were to form in a big quantity, it can potentially block off the artery completely within a matter of minutes, and immediately the patient can start experiencing symptoms. Sometimes the clot starts forming and it takes some time for it to totally occlude the artery. There may be some non-specific symptom, a little pain or a little discomfort for some time. Sometimes this kind of impending heart attack can go on for a few hours to few days even, and until then the patient may not have very severe symptom. Once the artery is completely occluded, then the patient usually complains of severe symptoms such as very severe pain in chest, sweating, and sometimes patient becoming giddy or becoming unconscious, etc. So it could happen in either way. Many times it's a sudden pain lasting for 5, 10, 15, 20 minutes. Sometimes there are minor symptoms for the preceding 1 or 2 days, and then suddenly the symptoms come on. So it's not always that we get a warning sign, warning symptom a few days ago. Sometimes it can be completely out of the blue.
Understood. Dr. Venkatesh, this is a bit scary, if I may, because we hear of people getting a clean bill of health after their health screening, maybe just very slightly elevated cholesterol levels. My question here is, or what I'm alluding to is, you spoke very, very passionately about how lifestyle changes have made us a little bit more at risk for lifestyle diseases. On that note, when you spoke about cholesterol deposits, is high cholesterol or, dyslipidemia, is this a modifiable risk factor or is it hereditary? I mean, there's so much of uncertainty around this topic. Can you help us understand this angle of it, please?
Coming to only cholesterol, dyslipidemia as a risk factor, there are two types of dyslipidemias. One of them is familial, as you pointed out. It could be familial hypercholesterolemia. The high cholesterol runs in families, and in these cases, the cholesterol levels can go in thousands. And we know that some types of familial hypercholesterolemia, the homozygous variety, can have premature heart disease very early, even in the second decade of life and all that. But in the common garden variety of dyslipidemia, what we see is a modifiable risk factor. While to an extent, diet and exercise can modify that, can reduce the total amount of cholesterol. Typically, when total cholesterol and the bad cholesterol, called as the LDL cholesterol, go very high, in general, it requires medical therapy to reduce that. There is a lot of skepticism about starting medicines for patients with high cholesterol. There are people who advocate lifestyle changes, diet therapies, and all that. But I would like to tell you one thing, that amongst all research that has happened in the field of cholesterol, there's one solid evidence, that is high LDL is a very important risk factor for myocardial infarction. And reducing this high LDL with the use of medicines called as statins is known to reduce this risk. When I say this, I know that a lot of controversy has erupted over statin usage amongst people. But whatever anybody says, that statins have side effects, statins are being pushed by pharmaceuticals, these kind of conspiracy theorists are abound. But no one has yet disproven this, that high LDL leads to myocardial infarction, and reducing LDL levels with statin therapy reduces myocardial infarction. So these two are very important points that we should remember.
Understood.
Thank you for clearing that out. I think we've had so much of controversy on that, and there's so much of stuff which comes out on media and print, and sometimes very difficult for somebody who's not a specialist within that field, who's reading it, not to get scared. So when we see that some days they say, oh, LDL is a good indicator, and the other day they say, no, LDL is not such a great indicator, and statins, it can cause side effects. I mean, it is confusing, and so thank you so much for clearing that up for us. I think on that note, let's take a break and then come back on the other side and discuss more with Dr. Venkatesh.
Every day, whether you're running, taking a walk, traveling, stuck in traffic, or just doing nothing, tune into the Old Couple podcast for great company every fortnight on your favorite podcast network. a Pandemia Inc. production.
Welcome back to Beyond the Diagnosis, not your typical medical podcast. We are speaking to Dr. Venkatesh, an interventional cardiologist. Just before the break, we left off at a very interesting point about young, healthy individuals who've been issued a clean bill of health suddenly experiencing symptoms related to cardiac illnesses. Dr. Venkatesh, could you make us understand what we're missing out on? Number one. And number two, we've noticed of late hospitals try to throw in health screening packages that talk about the coronary artery calcium score. Could you sort of enlighten us around this area?
That's a wonderful question, about the whole health screening, also called as preventive health checks in various hospitals. A lot of tests are thrown in, physicians examine, and then we try to predict what's going on here. So there are good things about preventive health screening and also bad things about it. So we have to understand what they do and what they don't do. Now, the thing is that the main understanding we should have is preventive health screening by itself will not prevent cardiac events, heart attacks, or death. There are a number of people who keep going back year after year, annual health checks, and come back with a clean bill of health, which you mentioned, and say that, oh, I'm fine. But they continue with their lifestyle or abnormal lifestyle, so to speak, saying that, okay, I'm fine. I don't have sugar, BP, cholesterol. So I can party, I can smoke, I can drink, I can be sedentary, I can put on weight. And these kind of things happen. So the clean bill of health, which the preventive health checks give, sometimes is dangerous because it gives a false sense of security. So what I say to my patients is, it's not the annual health check that protects you, but it's the lifestyle change which you do after that. Now, when you go to a doctor, your doctor looks at your history, your family history, your history of your physical activity, the kind of diet you take, the habits you have, and whether or not your tests are good. The doctor is going to make some recommendations given your previous profile, that you should make these changes in your lifestyle, and it is that is going to protect us, and not just annual check. So we have a lot of patients who come in, doc, year on year I'm doing tests, everything was normal so far. In fact, my last test was about a month ago. How did I land up with a heart attack? So this is what happens when we just rely on health checks alone. It has to be the lifestyle change. The other thing is, when it comes to people who take up exercise, for instance, we have a lot of people going on for morning walks or jogging or gymming, and they feel somehow this kind of exercise and their capacity to exercise makes them immortal. I have patients who come and tell me, I go for a 5-kilometer jog every day, but the same person is smoking through the day, partying hard every weekend, and their diet is all over the place. Now, if we take up exercise activity, for example, it is not that itself is going to negate the rest of your profile. Exercise should be a part of a healthy lifestyle. In addition to exercise, we have to make changes in our diet and habits. When you exercise, you hang around with healthy people. You have to talk to them about health, how to improve health, and how to prevent disease, rather than going for a smoke after a jog. So that is very important. So when it comes to preventive health check, these things have to be remembered, that it's not the health check, but the lifestyle change that protects us. The other point about coronary artery calcium is very interesting one. Coronary artery calcium score, or CAC score people call it, is an important screening tool that has been recently added to heart screening in many hospitals. Beyond your usual history, physical examination, blood pressure, sugar, and cholesterol profiles, some have advocated CAC score. Now, if somebody has calcium deposited in the arteries of the heart, it can be detected by a plain CT scan. It's a short run of a CT scan, few seconds it can be accomplished. It's a very easy test. If somebody has a very high calcium score, then we can say that the person has already got some blocks in the heart, maybe small, maybe large, but blocks have already developed. And these are the patients who are likely to have more cardiac events. So this CAC score is an important screening test to say whether somebody is prone to developing heart disease or not. But there's a caveat one has to remember. Now, coronary artery calcium deposition happens if the cholesterol deposit in the artery has been there for a long time. Sometimes it it takes decades for the calcium to get deposited on a cholesterol block. So therefore, if a young person has a CAC score of 0, it is no guarantee that that person has no blockages at all. In fact, there is a elegant study from one of the Scandinavian countries where they looked at a large number of calcium scoring scans, and they found that nearly about 14% of young people less than 50 years who had calcium score of 0 had some or the other blocks. So which means calcium score is a good test for people above 50. If let's say somebody who's 55 or 60 has a calcium score of 0, there's a fair amount of certainty that the person may not have any blocks in the heart. But at the same time, if a younger person has a calcium score of 0, it is no guarantee that there is no blockage. So young people, when they go for these kind of health packages which include CAC score, have to be a little careful. It is more designed for older people than younger. I hope I was clear on.
Oh, that is very enlightening and very surprising. Thank you for that, Dr. Venkatesh.
I think what interested me the most was what you were saying about the people who run. And, very commonly we see people who go for these marathons and then they do 10 kilometers and then they do 20 kilometers and then they drop dead. And the funny part, which you were saying was, after they do these 5 kilometer and 10 kilometer runs, not only are they going for that smoke, they're going for that big brunch which they do after they go and they sit down and they all get together and have a good drink and eat all those calories back again. And then so yeah, it's basically a big lifestyle modification which is required.
Dr. Ashish, it's a beautiful point you brought out that, people are doing this 10 kilometers, 20 kilometers. What we have seen is there is a lot of people getting recruited by proxy. Somebody in the office is joining a marathon, who's running a marathon year after year. Somebody else gets inspired and they also sign up. Typically, we see this that somebody signs up for a 10 kilometer or a half marathon 2 months or 1.5 months in advance, saying that I will also run. Now, what is important about exercise, endurance exercise, or even gymming is that it has to start low and build slow. Whatever exercise program we are signing up, unless it's a gentle walk, whatever exercise we are signing up, we have to make sure that number one, we are fit enough to do that. Number two, we have to train scientifically. You can't scale up suddenly. This is what is seen in many people. Somebody ran 5 kilometers today and went for a 15-kilometer run tomorrow. So that kind of sudden scaling up activity is bad. Why? Because I told you about this cholesterol deposited in the artery, which is covered by the thin membrane. When there is accelerated blood flow through that artery, it exerts a stress called as shear stress. It's like cutting off a branch or something like that. So that pressure can crack the artery and that can cause clot formation, and within minutes the patient can have a heart attack. So when we see some patients who, while running a marathon or while extra hard gymming, dropping down with a heart attack, one of the possibilities is this. It is therefore very important that number one, as you said, not have those carb loading after exercise and smoking after exercise. Those things have to be there. But in addition, whenever we sign up for an exercise program, we have to be very careful as to train ourselves scientifically and not scale up with a false sense of achievement. The personal bests and all that are sometimes to the detriment of us. So we have to be, respecting our body, not just trying to achieve some podium positions.
I think the take home over here is start slow and build up. Don't go gung ho as soon as you see the gym and then you say, I want to go hit it. But Doc, while you were talking about the exercise, what about the diet? Do you think people should avoid certain things, or, even diet in moderation is good enough?
Well, if you ask me personally, and I think there is now enough evidence building upon it, the single most important lifestyle factor that is affecting cardiac health of our people is diet. What has happened in the last 3 or 4 decades in our part of the country is there is economic liberalization. In addition to that, what happened as people became more educated and aware, the advisories given is that reduce fat intake, and also things like reduce red meat, egg yolk. So all of this has led to one commonly identifiable factor, that we are consuming way more carbohydrates than ever before. We read in our high school that our balanced food contains 40% carbs, 30% proteins, and 30% fats. But if you cut off a good amount of fats and a great amount of proteins, now what happens in our diet is a typical Indian diet, for example, has about 70 to 90% carbs. In addition, what has happened? The carbohydrates are now highly refined. We see that the rice is extremely polished. Technically, there is no nutrients in them. It's just carbohydrates. The flour, the wheat flour which we eat, is also so sieved that all the fiber and the goodness is all gone. We just have the white flour. Lot of the food which we get from outside or go and eat in the restaurants, like the Indian breads or even the breads and other bakery items, is made of what is called as maida, which is all purely no nutrient value at all. So all of this, and there is a huge increase in the amount of sugar which we are eating today. Look at the aerated drinks. We all know that a bottle of cola has 10 teaspoons of sugar. So overall, what has happened is there is a huge increase in total carbohydrate consumption, especially refined carbohydrate intake. What has happened is people have looked at dietary patterns. There was a study from McMaster University, Canada, headed by Dr. Salim Yusuf, who was from Bangalore, incidentally. They found that in a study, looking at 18 countries, that it is not the increase in fat content in the food that leads to heart disease, but it is the increase in carbohydrate content. This increase in carbohydrate content has led to all the lifestyle diseases like obesity, diabetes, and consequently heart disease. So this is a very, very important dietary change that we need to bring. I think overall what we need to do is we need to cut carbs. We are eating way too much food than what we need. We are not working in the fields. We are not cycling 30 kilometers for our work anyway. In addition, we eat too many times a day. I think human being is the only species who eats by the clock. Oh, it's 8 o'clock, let's have breakfast. It's 1 o'clock. No animal does this. So we eat too many times and we snack too often, and all of it is carbohydrate. So I think we need to have a moderation of our food. That's very, very important. I think, in my opinion, cutting down on carbs and moderating our diet is probably the single most important intervention that can reduce cardiovascular disease burden in countries like India.
So, Dr. Venkatesh, what we understand today as the typical Asian diet is
Yep,
killing us.
that's true.
I think we were speaking to Dr. Shalini last week, endocrinologist. The whole idea is not lose the carbs, let's just eat only red meat and fat. That's not your takeaway from this.
No. I'm not saying that. What I'm saying is reduce the refined. See, I know that there is a dichotomy here. There are on one side extreme low carb advocates who say, you have keto, and somebody is there is a carnivore diet where they eat nothing but meat, and there's something called paleo, etc. On the other side, a large number of physicians, endocrinologists included, continue to advocate small frequently meals, which is ridiculous because every time we eat a meal, we secrete insulin, and that adds to insulin resistance. And this insulin resistance and hyperinsulinemia is the one which causes obesity, diabetes, atherosclerosis paradigm. So this is well known. So I am not saying that don't take carbs. I am saying you tell us that you need to take 40% of the carbs, and you come back and tell I had rasam rice today or a paratha with a bowl of curd today. Where is the 40% carbs there? It is 70%, 90%. We keep blaming red meat. There's a patient of mine who came who had a heart attack at, say, 39 years. His dad complained to me saying that this man eats non-vegetarian food every day and that's why he got a heart attack. I said, what non-vegetarian food does he have? He said there is a biryani joint in front of his office, so he eats a biryani every day. Come on, there's a huge amount of white rice in that biryani and two small pieces of chicken or mutton or whatever you call it. You blame the chicken or mutton for the heart. No. All I'm saying is cut the amount of carbohydrates you are taking, cut out refined carbs, and especially cut out sugar. So I think these changes have to be subtle. I'm not asking you to change diets dramatically, go from, and it's non-sustainable. Somebody goes on to keto diet. It's great. they have a wonderful experience of bringing down their body weight, HbA1c, they feel great. 3 months later, they go back to their original dal chawal and they go back to being what they were before. So those things anyway are non-sustainable. I say cut carbs, reduce carbs, cut out all refined carbs and cut out most of your sugar. So that's what I'm saying. I know there is a huge misunderstanding between the low carb nutritionists, the keto nutritionists versus the endocrinologists on this. I have seen it on social media myself. But I think the word is moderation. It's not taking an axe and cutting off something.
Dr. Venkatesh, now we've spoken about prevention and the signs and symptoms which we see in people. But can we now go into the modality of treatment? Now, if you have a patient who you do identify early on as a potential patient who's going to have a heart attack or who has a cardiac ailment, is it that you need to do some type of interventional treatment, or do you generally start them off on some type of medication?
Well, I think all treatment in all fields of medicine is true that it has to be tailor made according to the stage of the disease in which and the patient's own condition, the other physical aspects of the patient. So, typically, if a patient has a mild disease, we are talking about ischemic heart disease, I guess, because we are talking about heart attacks and all that, so blockages, etc. We're not talking about people with hole in the heart and valvular heart disease and all that. So when it comes to ischemic heart disease or coronary blockages, if the patient has mild disease and no symptom, all we need to do is to prevent the progression of symptoms. So a holistic approach of good counseling, prevention of other factors from coming in. For example, if a person is not already a hypertensive, to help them reduce the chances of not becoming a hypertensive or developing diabetes, and talking about diet and physical activity, cessation of smoking, moderation of alcohol. And then there are medicines which are known to protect against impending heart attacks in those patients who have early disease. If patients have symptoms, when we talk about symptoms, there are two kinds of symptoms. One is the long term symptoms, like what we call as angina. If somebody walks, there is chest pain, the person stops, the chest pain goes away. So this is generally because of narrowing of the coronary arteries. That means the patient has atherosclerotic disease in the heart, and such patients are typically treated with medicines, give good angina relief, and make sure that the person has normal lifestyle to perform all the daily activities whatever the person has. If the patient has symptoms which are beyond the ability of medicines to control, that is the time when we generally advocate that patient should undergo testing, for example a CT scan or an angiogram, to determine the extent of the blockage. And if there is certain amount of blockage, various treatments like angioplasty with stents or bypass surgeries are advised in this. So it all depends on the stage of the disease. But as far as the sudden symptoms are concerned, we are talking about heart attacks. There are two types: minor heart attack and major heart attack. We call them as ST elevation myocardial infarction and non-ST elevation myocardial infarction. These are medical terms. But if we say that minor heart attacks and major heart attacks, typically the advice across the world is intervene early. You identify such patients, take them to the cath lab, perform coronary angiography, and generally we find that there are critical blocks and maybe some clots, and these are typically cleared off either by surgery or angioplasty. Therefore, once we resolve a problem or we give some kind of alleviation of this problem, it is again important for us to come back to preventive cardiology so that these problems don't come back again. Now, this is actually a low hanging fruit. If you take general population, the percentage of people getting a heart attack is small. But if you take all those people who have already had a heart attack, the percentage of those people having a heart attack is very high. So this is called as secondary prevention. I think it's a very, very important area where we should kind of concentrate. And this is where we should talk about diet, lifestyle, smoking cessation, alcohol moderation, and exercise. I keep coming back to the same words again and again. I'm sorry, but I think we do not have in this part of the country enough number of cardiologists, enough cardiac hospitals to treat all the patients with heart disease. We can't perform as many angiograms as that is required. We cannot perform as many bypasses as required as we stand today in 1.4 billion population in India. Same holds true to our other South Asian countries as well. So it cannot be that doctors and hospitals can solve the problems. It has to be a preventive approach. We have to prevent people from getting into the hospitals in the first place. And that's why I keep using these preventive terminologies again and again. I'm sorry about that.
Dr. Venkatesh, you were talking about the angiogram. Now, that's a very interesting thing. Now, correct me if I'm wrong, but is it the gold standard for diagnostic within cardiology? And is it really safe? Because there's a lot of concern with a lot of people when we say, okay, why don't you go and get an angiogram done? But they would be like, oh, is it safe? Is it not safe? So, can you clarify that?
I would say it is the gold standard for diagnosis. A coronary angiogram provides these informations. One, it tells us whether there are blocks or not. It identifies what percentage of narrowing is there, how much, what is the extent of block. And third, it also tells us how do we get rid of these blocks or how do we treat these blocks. Whether it is medicine or surgery or angioplasty, it will clearly tell us. The test is a very simple test. Through a needle in the wrist or in the thigh, a tube is inserted, through that a dye is injected, and some photographs are taken of the heart as the dye flows into these coronary arteries. A typical angiogram takes about 12, 13 minutes, 15 minutes at the most. And it's relatively painless. It's just a pinprick. Other than that, there is nothing else. Now, as far as the safety of the coronary angiogram is concerned, angiogram is unsafe in a very, very small percentage of patients. Patients with extreme weakness of the heart, patients who are very, very old, patient has some bleeding tendency, patient has a kidney disease, or patient has a very severe narrowing of certain valves. So these are rare patients in whom coronary angiogram is unsafe. Even amongst the normal people, there is, of course, no procedure which is 100% safe. But I would say a safety of a coronary angiogram is more than 1 in 2,500. We rarely see a patient who is walking and talking get into major complications during a coronary angiogram. I mean, none of us should ever think that coronary angiogram is an easy test, and we should never be done in a casual manner. We should take all due precautions, but when due precautions are taken, it's a very safe test. So sometimes the information we get out of a coronary angiogram is so critical, so important, and such life-saving that the small risk which we kind of take for undergoing the coronary angiogram is certainly worth it. So I think where indicated, wherever it is necessary, it's quite a good test to go through.
So what about somebody, a middle-aged guy, like 40 years old, no other ailments, he wants to just get his cardiac screening done? What would you suggest for him if he comes inside?
I would first go through the history of the patient, the family histories. What are the habits of the patient? What kind of physical activity the patient is going through? What kind of diet the patient takes? And then I would like to look at what is the blood pressure? What is the blood sugar? Is there any elevated cholesterol? These kind of risk factors should be first seen. A simple test which is done in a completely asymptomatic patient is some kind of a stress test. If you subject a patient to a stress, it could be a treadmill test, or it could be a stress echocardiogram, or a stress thallium test, or whatever. If we do a stress test, if there are critical blocks, it will generally tell us what it is. We come back to this question of CAC score. I would again say that if it's a 40-year-old person, coronary artery calcium may not be the best test for screening that patient. So I think if a patient has no symptoms, reasonably physically active, and passes these tests, BP, sugar, and cholesterol, and has no significant family history, I won't be taking him into a cath lab to do an angiogram or a cardiac CT. I know that there have been some senior doctors in the country, after some celebrity deaths, going ahead and telling that every person should have a CT coronary angiogram. I think nothing could be more misleading than that. It is not possible, first of all, to perform CT coronary angiogram on 100 million people in this country, number one. Number two, it carries way too much radiation and way too much risk. And the kind of fear psychosis one can get if somebody sees a minor cholesterol depositions at the age of 35, patient is going to live in fear forever. Instead, as senior doctors, we should be advocating very strongly lifestyle changes. The CT scan is not going to protect you from having a cardiac event. The change in your lifestyle is going to. So we have to talk about preventive cardiology in terms of change in your lifestyle, not in getting tests done.
So, Dr. Venkatesh, we've been talking about the diagnostic values of each different diagnosis, but ultimately it comes down to treatment. And one of the terminology which we hear a lot is stenting. So there are a lot of people who don't really know what stenting is and what we're doing over there. So if you could throw a little bit of light on what that is and who really requires those type of surgery. I know you can't explain it in real detail because, there's a lot more that goes through it, but, if you could just touch upon it and just give us an understanding.
Well, physically, the procedure of stenting is very simple. There is an area of narrowing in the coronary artery. So through a small tube which is inserted in the wrist or in the thigh, what we first do is we pass a balloon. It's a balloon catheter. It's in a collapsed form. This balloon has a long handle. So we take it up to that narrowed area and we expand the balloon so that the narrowed area becomes wider. In a majority of cases, once the balloon is used to expand that area, what we do is we insert a stent in the same place. Now, why we do that is because once you expand a balloon and widen the artery where it was narrowed, sometimes the artery re-narrows. So, to prevent that from collapsing back again, we insert a stent. Now, a stent is like a spring inside your ballpoint pen, and it is taken up using a similar kind of a balloon up till the place where the narrowing was, and there that stent is expanded. And now what happens is the stent sits like a scaffold. When you put concrete, you put a steel skeleton inside. So similarly, the stent will expand and hold the narrowed artery wide open. So this is called as a stent. Now, typically a stent is coated with some medications, and these medicines will prevent the artery from growing the block back. So this is the process of stenting. It's usually there are of course some complex kind of angioplasties which are done where stenting can be a difficult procedure even for experienced operators, but in a majority of cases it's as simple as I explained. Now, when do you do stenting is on one side, if there is a patient who has this chest pain every time they walk and what's called as angina, and when the angina is treated with medicines, there is no relief from angina. So in that case, we may have to widen these arteries with a stent, and then there is typically a relief in this angina symptom. The other kind of circumstance where we perform stenting is when the patient comes with a heart attack. As I said, the heart attack is because of sudden narrowing and occlusion of arteries. The artery is totally blocked. So what we do is using a balloon or some vacuum suction, we clear out that area where the clot is, and inside that we keep the stent and widen the artery. So this is again another area where stenting is extensively useful. So in a heart attack and in patients who are not responding to medicines for chest pain. So these are two circumstances in which stenting is commonly used.
Thank you, Dr. Venkatesh. I have to say, the amount I have learned just by listening to you today, this has surpassed anything I have looked at medical school. Now, why I say that, of course, I've learned the basics. I know how to manage patients, but to really take a step back and embed this in how we've been living, I think that's something nobody calls you out on. And that has to be the major take home message today. If I could just recap what you've shared with us, there are three major terms that are used interchangeably, which is cardiac arrest, heart failure, heart attack. But as you've clearly said, one does not lead to the other, and each of it has its own definition. There are three major arteries supplying the heart, and when there is problem with the supply, you then start to have pathologies or symptoms arising. A clean bill of health does not guarantee, or it's not an absolute indicator of heart health. Therefore, as you've clearly put out there, if you're 35, just starting a exercise regime, start slow, get yourself checked out, go for a complete health screening. Above the age of 50, yes, then you can include any form of the CAC scoring. You can include a more thorough screening, and this will be a perfect segue to how people have viewed angiograms, how there's overuse. But then, as you've clearly said, does the risk outweigh the reward, or does the reward outweigh the risk? Truthfully, the reward outweighs the risk because it gives you meaningful information that you can act on. And finally, I'm going to say this is the piece de resistance, which is your passion, which is preventive cardiology. Nothing goes away from consistency. Get into the right sort of lifestyle. Eat right, move right. Start slow, but be consistent. Do not go for things like vaping, smoking, excessive alcohol consumption. And I would like to say, Dr. Venkatesh, before I just end today, is there anything else, any last words you'd like to add on to that very short summary?
So I think you summarized it pretty beautifully. You brought in all the elements which we discussed extensively. I really enjoyed having this talk with both of you. It kind of gave me an opportunity to tell that, okay, while I'm an interventional cardiologist, I don't want patients to come to my cath lab. I don't want to earn from your misery. The old adage that prevention is better than cure is always supreme.
Thank you, Dr. Venkatesh. Thank you, Dr. Viroshini. Again, such a great conversation. To all of you out there, thank you for joining us. Thank you for supporting us. We are a new show, so please subscribe and do like us. Check out our link in bio, Twitter and Instagram handles. Dr. Venkatesh's link in bio will be there in the description, so do reach out to him if you have any queries. Until the next time, this is Beyond the Diagnosis, signing out.